Hello and welcome to the University of Washington, Washington Area Cardiometabolic Project Echo Session 5. I'm Nicole Earhart, one of the adult endocrinologists of the University of Washington Diabetes Institute. Today, Barbara Uneman is going to be giving the fifth lecture. She's going to be focusing on GLP-1 receptor agonists and our newer GIP-GLP receptor agonists and insulin-sparing injectables. As well, Dr. Carol Alchin will be presenting a really great complex insulin case. So thank you so much for doing that, Carol. And then finally, I'm going to have our panelists introduce ourselves, and I'm going to start with our speaker. So go ahead, Barbara.
Hi, good afternoon. My name is Barbara Onoma. I am a practicing adult endocrinologist in Maryland.
And then Lorena Wright, go ahead and introduce yourself.
Hello, my name is Lorena Wright. I am an adult endocrinologist at the Diabetes Institute in Seattle.
And great. And we have our great pharmacist today, Faiza Alibi. Please introduce yourself.
Hi, nice to meet everyone. My name is Faiza. I'm one of the clinical pharmacists at the UW Diabetes Institute and Lipid Clinic.
But without further ado, let's go ahead and start our fifth lecture. Go ahead.
So we're going to be talking about today, as has been already mentioned, GLP receptor analogs, and we'll focus on cardiovascular and renal benefits. We'll also talk briefly about GLP, GIP, the only one in that class at the end of the discussion. So hopefully in the next 20 to 25 minutes, we'll have a good discussion on this drug class. So here are the objectives of today's discussion. We'll review the different GLP receptor agonists and the different the general mechanism of action. We'll hopefully understand how efficacious these medications are and the benefits of this drug class on the cardiovascular and renal system, and also the use in liver disease, particularly recent publications and findings in metabolic associated hepatic steatohepatitis, what previously called NASH, and also the potential adverse effects of these medications and ways to mitigate or minimize the side effect profile. So I have no disclosures, and I will not discuss label use and or investigational use of medications in my presentation. So I'm sure most people on this panel know that diabetes is a progressive disorder, and even before the diagnosis of diabetes, complications have probably already started. And this publication, it's an old publication, shows this cartoon that prior to the onset of diabetes or the diagnosis of diabetes, both micro and macrovascular complications have already began. And presence of diabetes is associated with about a 2 to 4-fold increase in the occurrence of cardiovascular disorders, particularly coronary artery disease and stroke. So it's important that as we manage diabetes, we're not just controlling sugars, but if we can actually start impacting or reducing the complications or the risk that increases the complications, and if we have medications that can actually impact that we use those specific medications. So some of our scientific organizations have helped us every single year with algorithms that allows us to stratify and also choose medications based on comorbidities that our patients may have in addition, so that we can choose the correct medications, because every patient with diabetes might benefit from a different group of medicines to manage their diabetes depending on what other medical condition they have. So this is actually the 2024 ADA guideline that actually gives us an algorithm to consider choosing medicines like GLP-1 receptor analogs for persons who may have atherosclerotic cardiovascular disease as the second line after lifestyle modification and metformin, compared to persons who perhaps may have heart failure or CKD and considering other drugs in those persons as the second line. So when we talk about GLP-1 receptor analogs, what are we talking about? So GLP-1s are medications that have been around for a little bit of time. And glucagon-like peptide 1 is a 30 amino acid peptide hormone that's produced in the intestine, and is produced in the epithelial endocrine cells of the intestine, specifically in the L cells. And it has multiple actions in the body. And so this cartoon illustrates all the sites in the body where GLP has receptors and has roles or actions in the body. The four major sites that we're usually thinking about the effects of GLP are the pancreas in terms of the islet cells, that GLP can increase the production of beta cell function to increase insulin secretion. It also reduces glucagon secretion, so that helps with improving glucose levels in the blood. It also helps with satiety, which means that it reduces hunger and improves satiety, and this in turn results in decrease in body weight. So that's its effect in the brain. There are other sites as well that the GLP affects, including the intestine. It sometimes would cause slowing of gastric emptying. That also helps. It decreases gastric emptying, and that sometimes can contribute to some of the side effects that we'll talk about later, but that in turn also contributes to some of the weight loss that happens with GLP. And there's several, I'm not going to mention each and every one as you can see on this cartoon, but there's several sites, including another potent effect that has been discussed in the literature, particularly as it pertains to decreased inflammation and its effect in the cardiovascular system. In 2005, the first GLP drug was introduced. So sorry for this very tiny slide, but in 2005, exenatide was the first GLP that was introduced in the market in the United States. And this was a twice daily injection. And since then, multiple GLPs have actually been available for use, and each one of them has resulted in significant glucose lowering. But as we will soon find out in this lecture, there have been other benefits that have been even more important in the use of these medications, more so than just the glycemic effects of these medications. So exenatide, which was marketed as Byetta, was first available on the market in 2005. And then was followed by lixazenatide, which was really never available in the United States as lixazenatide alone, but was available as a combination with glargine insulin and marketed as Soliqua. And then it was followed by liraglutide, which is Victoza, which was a once daily injection. And then exenatide became available as once weekly by Durian. And then we had the first once weekly, which was the dulaglutide, and followed by abiglutide, which is Tanzium, and then semaglutide, which is Ozempic, and then followed by dulaglutide, which is Trulicity, and then most recently we have the combination of the GLP-GIP, which is tirzepatide, which is Mounjaro. So this is sort of the natural history or the progression of the GLPs and development and since 2005 and the availability on the market. These medications are very effective in terms of their glucose lowering. So this graph is showing that both the short acting, which is the once or twice daily GLPs, as well as the long acting, which is the once weekly GLPs, can result in upwards of 2% drop in A1Cs, as well as significant drops in weight up to 15 kilograms of 15 pounds or more weight in this graph that is showing for this GLP. So these are very effective medications. Prior to these GLP-1s or medicines like GLP-1s becoming available, most of the medications that we had that were non-insulin would be able to lower A1Cs as monotherapy by just maybe 1 to 1.5%. So they are classified as being very potent or as potent or very potent when you look at all the guidelines that we have in terms of medications that we use to treat diabetes. And in addition to their glucose lowering effect, they also do have some of the medications, not all, cardiovascular benefits, specifically dulaglutide, liraglutide, and semaglutide. And we will look at those studies specifically in the next few slides. So this forest plot is looking specifically at results of cardiovascular outcome studies comparing GLP-1 receptor analogs with placebo on background of standard of care. And is looking at studies that looked at majority of the GLP-1s that we've just mentioned, lixazanitide, semaglutide, exenatide, albiglutide, and dulaglutide, as well as oral semaglutide, which is the only oral GLP available. And when you look at the cartoon in panel A, on the forest plot on panel A, you can see that for majority of these trials, there was significant improvement and reduction in the hazard ratios for major adverse cardiovascular events, which is for LEADER trial, which looked at liraglutide, there was a significant improvement in cardiovascular risk. Same for SUSTAIN 6, which looked at semaglutide, and the same for the REWIND trial as well. And when you looked at meta-analysis on panel B that looked at all these trials together, the same held true. So I'm going to focus a little bit on the LEADER trial because this was the first cardiovascular outcomes trial for GLPs that really brought to light the importance of these medications in reducing cardiovascular risk. This study design looked at a large number of patients, over 9,000 patients, and the reason why these studies became popular anyway was that after 2008, the FDA required that any diabetes medication that got approved needed to show that there was no cardiovascular harm associated with it. And so this study was not only looking to show that there was no cardiovascular harm associated with liraglutide, but in addition to that, it also showed that there was cardiovascular benefit. And so this study showed that in these patients who were randomized to 4,000 patients randomized to liraglutide, and then over 4,000 patients randomized to placebo, the primary endpoints that they were looking at was a 3-point MACE, which was cardiovascular death, non-fatal MI, including silent MIs, or non-fatal stroke. And then they had a few secondary endpoints as well as listed on the slide. And they followed them for a total of over 3 years. And they found that there was a significantly lower rates of all-cause death, which was very important, as well as a decrease in cardiovascular death with liraglutide. So there was increased rates of gastrointestinal events with liraglutide-treated patients, which is a known side effect of these medications. And they did see lower numerical incidence of pancreatitis in liraglutide group as well. This was not statistically significant, and this was important to note since this was one of the concerns with using GLPs. So this is the forest plot for the study we just looked at. And as we can see, for all the endpoints that were looked at, the endpoints were in favored liraglutide. So we see the hazard ratios were all in favor of liraglutide. Then there was a second study, which was the study with semaglutide, which was a much smaller study and looked at 3,000 or little over 3,000 patients. And again, it was the same 3-point MACE of cardiovascular death, silent MI, or non-fatal stroke with similar secondary endpoints. And in this study, they actually also did look at new or worsening nephropathy. And what was found in this study was that there was significant benefit that favored semaglutide in the major cardiovascular events. So all-cause death and non-fatal MI and non-fatal stroke significantly favored the use in persons with semaglutide use. The REWIND trial was a trial that looked specifically at dulaglutide use. And this trial was a little different from the first two that we've just discussed because this looked at persons who had not had any event, but with persons who were high risk, which was more of a primary prevention study. And in this study, dulaglutide was noted to be superior to placebo in improving glycemic control and also reducing cardiovascular events, particularly stroke, in patients who had type 2 diabetes and had higher cardiovascular risk. And these were really important findings because it was thought that this medicine would need to be considered for the management of persons with type 2 diabetes who were high risk and could be used as primary prevention. And this was the first study that had a higher percentage of persons enrolled in there who had not had an event before and so would have been considered as being used as primary prevention. So thus far, the three main GLPs that we've discussed that have all shown significant benefit in terms of cardiovascular risk reduction. Liraglutide did show, dulaglutide, which is in the REWIND trial, and semaglutide as well. Oral semaglutide, which is marketed as Rybelsus, has also been studied. And in the study for Rybelsus, the study was a little smaller and was also significantly shorter. The Rybelsus study did not reach statistical significance. The primary outcome was time from randomization to the first occurrence of death from cardiovascular causes, non-fatal MI, or fatal stroke. And what they found in this study was that comparing the persons who got Rybelsus or oral semaglutide to the persons who got placebo, the events were relatively similar and it did not reach statistical significance. So when you look at all of these studies together, and you look at studies that included persons who have a history of cardiovascular disease on the top panel, and studies that included persons with no history of cardiovascular disease on the bottom panel, the LEADER trial, which is the liraglutide study, SUSTAIN 6, which is the semaglutide study, and the REWIND study, which is the dulaglutide, which is the Trulicity study, all are in favor of reduction of cardiovascular disease and favors GLP-1 receptor analogs. And then in the studies that had no history of, we look at persons with no history of cardiovascular disease, REWIND is the only study that actually shows statistical significance, which means that if we're looking for a GLP in terms of primary prevention, that would be the one to consider. So now going to renal effects, there's been some talk about whether or not these medications have any benefits in terms of renal benefits. And there have not been specific studies or as many specific studies in terms of renal benefits for GLPs as there have been for the cardiovascular trials. So it looks like for the cardiovascular trials, it's clear-cut that there is cardiovascular risk reduction with specific GLPs. With the renal studies, it's been a little bit not clear-cut for two reasons. One, because most of the renal studies have been using secondary endpoints or secondary outcomes. And two, because the renal studies have usually looked at two endpoints or two metrics and put them together. They've used both EGFR as well as albuminuria and just clumped them together. And whilst both factors look at kidney function, they should be separated because they're looking at two different metrics. But if we look at the meta-analysis of cardiovascular outcomes trials with GLP-1 receptor analogs on renal endpoints, these would be secondary outcome measures that are being looked at. And the only one that really points out that there's been significant improvement would be the study that was done with the SUSTAIN trial, where there was a significant improvement. However, overall, you would see that in the meta-analysis, there seems to be a trend towards improvement in renal endpoints with all of the GLPs, except for in the ELIXIR trial, where there was no statistical significance. Questions do come up when we're talking about GLP-1 receptor analogs in terms of dosing in persons with CKD. And the most concern happens with whether or not these medications can be used in persons with higher stage renal disease. And so this is a sort of guide to help decide whether or not these medications can be used in persons who have a higher stage kidney disease. And there's really no significant contraindication. It has to be used with caution in persons who, of course, are on hemodialysis or have higher stage kidney disease for most of the GLPs because of the significant nausea and gastrointestinal symptoms that can be worsened, even more so in persons with CKD. Most recently, and this past summer, the FLOW trial was published in the New England Journal. And this was a study that randomly assigned patients with type 2 diabetes and chronic kidney disease to semaglutide. And they looked at their progression of kidney disease, and the outcomes specifically looked to see if persons progressed on to either dialysis or death from kidney disease or worsening of their kidney function. And the trial was stopped early at a median follow-up of 3.4 years after an interim analysis showed efficacy. The semaglutide group had fewer primary outcome events than the placebo group, and this was equivalent to a 24% lower risk with semaglutide. So this is actually the most definitive study looking specifically at GLP effect on renal function and showing a positive outcome in terms of improvement in both eGFR as well as a slowing of decline in renal function. And if you look at the numbers, it says at least 20 people will need to be treated with semaglutide over a 3-year period to prevent one major kidney disease event. So what are some of the potential side effects that we would encounter? Would we use using GLPs, and how are some of the ways that we can mitigate those side effects? The most common side effects that are noted in a GLP-1 is nausea, vomiting, diarrhea. That's the gastrointestinal. And most prominent is at treatment initiation or titration. This can be mitigated by instructing our patients to eat smaller meals, stop eating when they feel full, drinking water with their meals, avoiding fatty or very rich foods, and not laying down right after they've eaten, going for a small walk after they've eaten. All of those things would help to slow down or prevent the nausea that can happen with some of these medications. Usually, after they've been on the same dose for a while, the symptoms usually abate. Some of the studies showed no significant signal for pancreatitis or pancreatic cancer. However, there's always a good idea to counsel patients on signs and symptoms of inflamed pancreas so that people would know if they had severe abdominal pain that radiated to the back to at least stop the medicine and get evaluated appropriately. The absolute contraindication for this medication is to not give it to persons who have family history or in themselves history of medullary thyroid cancer. So C cells of the thyroid contain receptors for GLP, and we're supposed to avoid use in patients at risk because of family history or if they've already had history of medullary thyroid cancer. There was a risk of retinopathy noted, particularly with sub-Q semaglutide, and in SUSTAIN 6 trial, 3% of patients in the semaglutide group developed retinopathy compared to 1.8% in the placebo group. The factors that may affect diabetic retinopathy, of course, includes age and diabetes duration. So it's always important to ensure that patients are getting age appropriate and health maintenance that's appropriate for their diabetes in terms of health eye checks at the appropriate time, particularly if they're on sub-Q semaglutide. In 2022, about 2 years ago, the FDA approved the first GLP-GIP combination. And so this is the first of its kind and the only of its kind in the class. So the GLP, as we know, is one hormone that binds one receptor. This medication actually is a dual hormone, but binds to one receptor. So it's a vernacular or term for what is called a twincretin, as opposed to just a one hormone, because it's a dual analog, but it still binds to one receptor. And this trial that led to the approval of this is a SURPASS trials, and that showed that there was the tirzepatide even more potent in its glucose lowering effect and its ability to cause more weight loss compared to even the GLPs that we've just discussed. So tirzepatide showed a mean A1C reduction of up to 2.6%, so quite impressive for one molecule and one drug, and dose-dependent weight loss between 8 and 14%, which is very significant. Tirzepatide was showed to be superior to even semaglutide at its almost highest dose in head-to-head comparisons, and it was shown to be superior to insulin in reducing A1C and, of course, body weight with a lower risk of hypoglycemia, which was also quite significant when the papers were first published. These are some of the graphs that show the different dosing of tirzepatide. Tirzepatide is available at its lowest dose at 2.5 milligrams, and then the dose is increased 2.5 milligrams. From there also is 2.5, 10, and 12.5 and 15. And in these studies, they use the 5, the 10, and the 15. And these graphs are showing that at the 5, 10, 15, and milligram dosing, the significant change compare in terms of A1C comparing to the 1 milligram semaglutide, as you can see in panel A in terms of A1C. And you can see also in panel B that a higher percentage of persons met targeted A1C in terms of using different doses of tirzepatide when you compare it to the standard of semaglutide 1 milligram, which means that tirzepatide is much more effective even comparing it to 1 milligram of semaglutide, which at the time of these studies was the highest dose of semaglutide that was available. These graphs are showing similar in terms of change in body weight and changes in or the percentage in persons who met weight loss targets and improvements in lipids, again, all showing the effectiveness of tirzepatide compared to semaglutide. So again, this is the same graph, same thing that I've just shown, but in different ways. The SURPASS 1 to 4 trials is showing the effectiveness of tirzepatide when you compare it to semaglutide, and it's basically showing how effective tirzepatide was. Number of persons who were able to even get to a significantly lower A1C when they were on these medications, and how low their A1Cs were able to get to at different doses of this medication, but most importantly, without achieving hypoglycemia or getting major adverse effects. The one thing I wanted to mention about tirzepatide is that we're talking about cardiovascular benefits of GLP and renal benefits of GLP. And we know that there's specific GLPs that have shown cardiovascular benefits clearly. And those GLPs are the ones that are highlighted in green here. So liraglutide in the LEADER trial, semaglutide in SUSTAIN trial, some semaglutide in the SUSTAIN trial all showed a significant benefit, as well as dulaglutide in the REWIND trial. However, we thus far have not had cardiovascular outcomes trial published yet on the tirzepatide trial. So we cannot say with 100% certainty that tirzepatide has cardiovascular risk reduction, even though the trials are ongoing. So that's just to take note of as we practice evidence-based medicine. The trials are ongoing, and hopefully they will be published soon. So one last thing about tirzepatide. Tirzepatide had these recent publications, data coming out about tirzepatide for NASH and what is now called metabolic dysfunction associated steatohepatitis. Hopefully, eventually, we're going to all learn how to say this. But tirzepatide was shown in a recent publication at different doses to actually show a decrease in fat deposits in the liver, as well as slowing down fibrosis. And this is one of the first studies that have shown this, because in prior studies with semaglutide, there was actually sort of a neutral study where there was no significant decrease in fibrosis. So this is actually a very good signal for tirzepatide in terms of reduction, because we know that with fatty liver, if this fatty liver does not get, the fat in the liver doesn't reduce, eventually it can progress onto fibrosis and cirrhosis. And so this is a very good signal that if these studies are being able to reproduce, and if this is really holds true, then this would be a great medication to actually treat non-alcoholic liver disease and prevent cirrhosis. So we are aware that there are several GLP-1s, and when we're making a choice for persons who have cardiovascular disease, we always want to keep in mind which ones have evidence-based cardiovascular trial data to support using the particular GLP that would help our patients reduce. And the ones that specifically have studies that have shown them to reduce cardiovascular risk are liraglutide, which is once daily, that's Victoza. And then there is semaglutide, which is once weekly, which is Ozempic. And Ozempic is dosed 0.25 milligrams weekly for 4 weeks, and then advanced to 0.5 milligrams weekly for 4 weeks. Then it can be advanced to 1 milligram or 2 milligrams thereafter. And the dose is advanced every 4 weeks minimum. Doesn't have to be increased in 4 weeks, but cannot be increased from one dose to the next in less than 4 weeks. Ideally, it shouldn't. We know that oral semaglutide did not show statistical significance in its cardiovascular studies. And then there is dulaglutide, which is Trulicity, which did show significant cardiovascular risk reduction for both primary and secondary risk reduction. So the take-home points here are that GLP-1 receptor analogs generally quite effective and well tolerated. They reduce the risk of major adverse cardiovascular events in persons with diabetes, with the highest effect in persons with known risk of cardiovascular disease compared with those without. GLP-1 receptor analogs reduce the risk of kidney disease by causing a risk in albuminuria. Cardiorenal benefits may be mediated by their effect on A1C, BP, and other cardiovascular risk factors. The most common side effects are gastrointestinal, and the new GIP-GLP receptor agonists have even more A1C lowering, weight loss, improvements on metabolic profile, and GIP-GLP-1 receptor analogs may be an effective treatment for MASH and regressing fibrosis.
Thank you so much, Barbara. And it's so exciting, all the evolving literature. You heard about semaglutide and the kidney effect, and oral Rybelsus also has shown a cardiovascular benefit with 14% reduction in MACE through the SOUL trial, which just resulted the last week of October. So all this evolving things, and we're hoping tirzepatide will also have the cardiovascular endpoints, hopefully by the end of November, as Barbara mentioned. Does anyone have any questions for Barbara? One question I always get asked is when you have GI side effects, how do you mitigate those side effects in order to advance the medication and minimize things like insulin or maximize weight loss, Barbara? What are some of your tricks to the trade?
So it depends on what type of side effects people are having. So if, the side effects can be nausea, and if it's nausea, we try to do things like eating small meals, avoiding fatty foods, the things that I talked about. If it's constipation, we try to do things like Miralax in the water, making sure they're drinking plenty of water as opposed to other things that people may sometimes drink that is not very hydrating, making sure they're getting enough fiber. If they're getting this, we try to tell people to eat their biggest meal earlier in the day as opposed to eating their biggest meal later on in the day. So it depends on what particular gastrointestinal symptom people are having. But the most common gastrointestinal symptom that I see in my practice is the nausea and constipation. And for the constipation, if you stay ahead of it, so don't wait until you get really constipated before. And so trying maybe something like Miralax, that usually helps.
Thank you. Great advice. And I always tell people to use it as a tool an inspiration to walk after meals so that it gets the gut moving. And then sometimes I will put people on proton pump inhibitors just empirically if they have any history of reflux, just to minimize the risk for gastritis and reflux as we titrate the medication. So great discussion and great points. And so I'm now going to turn it over to Carol, and she's going to start our great case discussion. So take it away, Carol.
Okay, this patient is a 55-year-old female who has type 2 diabetes, and her main problem is that she gets very stressed out and her sugars go soaring. And how do we control this? She has diabetes type 2. She has PTSD. She has a history of sexual abuse as a child. And also her first husband years ago was very abusive. And so she has PTSD from both of those. She had a prolactinoma many years ago, 10 or 15 years ago, and has a residual seizure disorder from that, and also some residual sight loss from the pressure. Her current medication, she's on Synjardy, which is a combination of Jardiance and metformin. She's taking Mounjaro. She's taking insulin. I just recently started her on an insulin pump in an attempt to control her excursions. Lisinopril, simvastatin, Keppra, and she uses an albuterol MDI periodically, and she has an EpiPen because she has some allergy anaphylaxis reactions. Of note to her allergies and intolerances, she has a lot of GI side effects with metformin and Bydureon and the GLP-1s. She also is allergic to artificial sweeteners, which makes it a little more difficult for her dietary inputs. Family history is not particularly exciting. She's a student. She's going for a BSN currently, and she also works as a caregiver at a SNF, and her mother is also in the process of dying from cancer, and she cares for her mother, who she has sort of a interesting relationship with, and that becomes very stressful. And she's divorced, and she has one child at home who is adopted, who is an Asperger's. She never smoked, and she's not drinking at all, and never really a heavy drinker. Of note, she's overweight with a BMI of 42, and her labs really, her last GMI from her CGM was 7.6. You can see her cholesterol there. No diabetic retinopathy, and her microalbumin is normal. Of note, she does see a therapist regularly, but she has declined taking SSRIs or any other medications. You can see that her depression screening and anxiety screening score high. And her stressors currently right now, she's under multiple stresses. They're asking her to move out of her house because they're going to sell it, so she needs to find rent, and she doesn't have a lot of money. She's on Medicaid. Her mother's dying, and she's the caregiver. She has very little money because she only works part-time, and she has a son that she has to support. And she's working at school, and so you have the normal, exams and stuff. And working is also stressful. I mean, working at any SNF is stressful these days. She never sits down for a meal. she just kind of eats on the run, and sometimes she thinks she's going to eat and then the work gets in the way and she doesn't eat. So that's really difficult. And then I wanted to show you some of her sugars. I'm going to scroll down here. This is the CGM from the last 2 weeks, and there was a point where she was off the CGM thing, but you can see her glucose excursion. So she's all over the map. And I just wanted to show you a couple of incidences where she got stressed out and her sugars went soaring where she didn't eat. This is from the insulin pump, from the Omnipod pump report. And the little teal squares there along the bottom are carb entries. So that shows when she was eating. So you can see where I've put the bright blue arrows that she wasn't eating and she was stressed out. Most of these were related. Oh, this was, she'd come home and she'd work on trying to find housing. You know, she's looking at being homeless and trying to find housing. And in Port Angeles, the housing market is horrible, particularly for low income. So she would be stressed out and her sugars would go soaring. This is another instance where she ate about noon and you can see the glucose rose, but then she started getting stressed out caring for her mother. And you can see that even after the peak from her meal, her sugars just kept going higher and higher. And then these are a couple of things from a couple of years ago, but you can see on the first one, late at night at 10 o'clock at night, her glucose went way up. And also on the next one, you can see at 12 or 1 o'clock in the morning, her glucose surged. And this was from nightmares from her PTSD. So knowing how to keep her, I put her on a pump hoping that maybe we could do something to control these surges, but I can go back up to here and let's see here. These are just her daily glucose curves, CGMs from the pump. And I'll let, if whoever wants to talk to, this is when she was off the.
Thank you, Carol. A great case, really complex, and you're doing a great job with her. And there's a lot of great discussion. I had one clarifying question before I opened it up for other people to ask clarifying questions. What were her main side effects with GLP-1, GIP, and have we tried anything to mitigate those so we could maximize the tirzepatide anymore?
Nausea, GI stuff, and we've just tried to titrate slowly.
Great. Thank you for sharing that. So mostly just stomach upset then? Any vomiting?
I think she does vomit occasionally. She
Okay.
had been on 5. We just raised her back to 10, and she's been kind of, she's able to tolerate it, but she still has some side effects, but she's willing to tolerate the 10 so far.
Thank you for that information. Does anyone else have any clarifying questions for her? Okay, I'm going to turn it over to Lorena Wright, and we're going to go through some discussion points. We might not have all the answers, but we'll just keep working and supporting her together.
Great, very good. Yeah. So just to recap, this is a great case, right? Like challenging. So this is a 55-year-old female living with obesity. BMI is 42.6. Her weight is 252 pounds. And she has type 2 diabetes, poorly controlled. Diabetic retinopathy was mentioned as one of the complications, hypertension, PTSD, and seizure disorder. And now, we know that this PTSD is really affecting her glycemic control that we can really see in the CGM. She's a caretaker. She has a pretty stressful job. She has an aging parent and also a kid, right, who has Asperger's. No personal or family history of autoimmunity, and she is on an automated insulin delivery system with Aspar or Novolog, also on the combination Jardiance and metformin, which is great, and tirzepatide at a dose of 10 micrograms weekly, lisinopril, simvastatin, and her medication for seizures and an inhaler as needed. So that's the recap. All right. So then the first question, right, that we always ask, and because we never want to forget about this, even sometimes if we feel that it might be obvious, but is this type 1 or type 2? Do we think the patient is lipinic or insulin resistant? And I think, here we agree that this is mainly that there is evidence of insulin resistance and that it is most likely type 2 diabetes. There is no personal or family history of autoimmunity, and she has a family history of type 2 diabetes. So I feel very comfortable that that's type 2. And yeah, one of the main challenges with this patient is her PTSD and the life stressors. And this is her score, like that 7 anxiety score. And she scored moderate anxiety. So but her score is 12. So that's something definitely to consider, like when we are going to, the recommendations that we are going to provide to our patient. Okay, so then the second question that we should ask is, what is her A1C goal? And we always, like I kind of have this, you've seen this graph, but it is always important kind of to get back to this, because we do want to take into consideration comorbidities, in this case, her PTSD, her anxiety, and also patient preference. And when we talk about patient preference, it's not that the patients necessarily want to have lose control. It's more kind of like how motivated they are and how the challenges that they are facing, whether they will be able to achieve better control. And also this, every time we ask this A1C goal, this needs to be reassessed, right? Like, this doesn't mean that this is going to be a goal forever. This is kind of like where we are right now, what would be her A1C goal. And for this, this is kind of like also individualized. I would like to ask Barbara, like, what do you think? What would be, if you were seeing these patients, what would be a good A1C goal for this patient?
So this patient has a lot going on. So I think for this person, of course, ideally the goal is less than 7%. But for this person, since we're considering, I think an A1C of between 7.5 to 8 would be ideal. Looking at her glucose download, we see a lot of variability. So if we can get her to 7.5 to 8 and get rid of some of that variability, so she becomes a little bit more even keel, but then have less variability, that would be ideal. And then when things settle down a little bit, maybe we can tighten it up and go to less than 7.
Absolutely, I agree, right? Like, so in this case, we don't necessarily have to aim for an A1C that is very strict. We can, we always try to get better control, but I think like an A1C of 7.5, would be fine. And then we would reassess as things keep getting better and other comorbidities are addressed. So we first talk about non-pharmacologic strategies. So we always, have to start with lifestyle modification. At times when we cannot really, modify the stress that she has at work or where her aging parent and kid, but we can just talk a little bit about like, what are her eating patterns? What is it kind of like the typical foods that she eats? And when assessing that, then trying to select things that, that are good options and reinforce that. It's like, oh yeah, that's actually pretty good. Then let's try to have that more of that and less of this, without being too, create more stress or burden. She also has the challenge of having limited time to prepare meals and to exercise, because again, she has so much on her plate. But perhaps, giving options as meal prep, maybe on her day off, is that something feasible? And also, to be mindful about about activity. A lot of times patients feel that, exercise has to be very kind of like organized, join the gym, go. But if we kind of like emphasize, like, it doesn't necessarily have to be that way. We're all busy, but if we kind of like integrate any activity, any physical activity in our daily life, right? Like, so then cleaning our house instead of having someone else cleaning it, right? Like, or washing our car instead of having, just kind of like little things like that. You heard about like taking the stairs instead of the elevator. So just kind of like having those things in mind on a daily basis, that makes a difference. And then we have a caregiver, where she has significant life stressors. I always want you to think about, okay, these are kind of like our goals now, but that to keep in mind that, this is kind of like a work in progress. Our goals definitely can be modified later on. So this might not be the best time to talk about bariatric surgery in this patient, but do keep that in mind, right? Like, consider this in the future, given her a BMI. But again, I think like right now is not the best time to bring it up because of her life stressors. And the reason, like, I wanted to think about this, right, like is because, well, that is really the most effective strategy that we have for weight loss. And this pyramid kind of shows like the percentage of weight loss that patients achieve with bariatric and metabolic surgery, and then followed by injectable weight loss medications, as we review with semaglutide and other GLP-1 and GLP-1 GIP receptor agonist medications. And then we have also like meal replacement programs and lifestyle modifications and so on. So then we do want to integrate, like as many of these in our treatment for our patients living with obesity. So individualizing the treatment, really. So then considering bariatric surgery, considering when I show you this pyramid, right, like it's considering all of these steps, one doesn't necessarily exclude the other. And I also wanted to bring up that in the trials, what with tirzepatide, patients with obesity who did not have diabetes lost a mean 25.3% of body weight, which is really, remarkable. And what was interesting is that in the SURPASS-3 trial, patients with diabetes lost weight as well, not as much, but still, like quite significant, 13 to 15% on average in the SURPASS-3 studies. So I thought that was pretty interesting and kind of wanted to underline that. All right, so now getting back to this patient again. So she is on an insulin pump, right? Like, so then when patients are on an insulin pump, ideally we would want them to carb counting. At times that is not, possible immediately, but this is definitely, carb counting is something that they can master as they continue to be on an insulin pump. A lot of times, when I started patients on insulin pumps with type 2 diabetes, they might not necessarily start the pump right away and do carb counting, but that's something that they can totally learn as they continue using the pump. So I usually I think that starting with an insulin to carb ratio of 1 unit for every 10 grams of carbs is a good start for patients with type 2. So that means that 1 unit will cover 10 grams of carbs. And then to help them determine the amount of carbohydrates, I usually kind of ask them what is something that they eat very frequently, and then come up with how many grams of carb that specific meal has. So then they know, of the meals that they have more frequently, how many grams of carbs that is, and then they can start using that. And then again, as they continue using the pump, or they continue learning more, then they can, really get to master this. If they don't, if they don't really count carbohydrates, another strategy when patients are on the pump is to use this method that we call it 1-to-1. So for example, when a patient is already doing injections and they are injecting, I inject 10 units for lunch, for example, right? So that what they can do is they can put if they want to use 10 units of insulin, the pump they can put 10 grams of carbs, and then we would put the ratio in the pump, 1 unit for every 1 gram of carb. That way, the amount of carbs is kind of is reflective of the amount of insulin, the units of insulin they're giving. So that's another method. There is just many different ways to help patients with type 2 diabetes bolus when on a pump. And I hope that kind of makes sense, but again, strategies on patients with type 2 diabetes using a pump. So now the pharmacologic options that we have, so then the patient thankfully is already on tirzepatide. All of these medications, the GLP-1s, GLP-1 GIPs medications, need to be titrated slowly because they otherwise cause significant nausea. And so then it is recommended that these medications, they are titrated up slowly and monthly. So she is tolerating 10 milligrams weekly. So then, we should try to titrate again, but at a very, slowly rates. And if this has been tried again, but definitely, try to maximize. At times, what I've done as well, instead of doing 10 weekly, instead of increasing to the 12.5, for example, weekly, then I would recommend, okay, let's try 10 every 5 days, just so it's kind of a little slower if you wish than titration on a weekly medication. And now we'll talk about like insulin management. So then this patient is on the pump, right? Like, and this is the summary. This is the summary of her glycemic metrics and her pump use. And I'm sure you've seen some of these, right? Like, so then here we have the timing range is 36%. So that obviously is suboptimal and really not hypoglycemia that we can see. This is how her insulin is distributed. So 65% of her insulin is basal and 35% is bolus. So that suggests that, well, she's not really bolusing much, or as we heard, right, like her glucose seems to go up quite a bit, when she is having nightmares and also when she's very stressed. But there were some, graphs that were shared, here. And when, discussed with the patient, it seems that these were because of stress. But I would, having seen a lot of patients on pumps, and I would kind of like question a little bit more whether there was something to drink or a snack or perhaps not a meal, but a lot of times patients don't think of a meal, and it is when they take a snack, right? Because these are really remarkable increases in glucose. And then, we see here, like in the pump, right, like when she entered the carbs, she entered 120, 121, very close together. So those are carbs. And then after she did that, then, like the pump then gives the insulin, and then she drastically drops. So then one thing that I would worry here is that perhaps, she's having like some snacks or some drinks that raise her blood sugar in addition to her stress. Or she might then enter the carbs later, right? Like when she might not actually be eating all these carbs here. And then that's why then she might crash. What we call this, what we call this in patients who are using a pump is like ghosting, like putting ghost carbs or fake carbs. And that doesn't necessarily mean that they are not having those carbs, but they are not really having the carbs at that particular moment. So then
Can I interrupt for a second? You are very right. She was ghost carbing here. And I subsequently, so this was just last week, have taught her how to enter a bolus without entering the carbs.
Oh, yeah. Okay, good. Yes, that's great, right? Like, because then this, on the closed loops, this is kind of like the times when they can actually go low. If they kind of like ghost carbs, they put carbs that, and also because, like I had patients like this, is like it's not like they are not necessarily eating the carbs, they're just entering the carbs later because they might be worried of hypoglycemia. So then they let the blood sugar go up. And then, when the blood sugar is high, that's when they enter the carbs that they ate earlier. But that is not a good move, with the closed loops. So then just to be aware of that. But that, well, good. I'm glad that she now knows about ghosting or avoiding ghosting or fake carbs. Good. So let's see. And the other thing, like that I think is a good point here to discuss, and I'm going to ask Faisa, or a wonderful pharmacist, to talk a little bit more about these ultra fast acting insulins. Sometimes when the patients bolus, but they, before eating, but they still kind of like a spike, that's a good time to consider these ultra fast insulins.
Yeah. So, with our rapid acting insulin analogs, Humalog or Lispro and Novolog or Aspart, they're really designed to be taken 10 to 15 minutes prior to eating to give the insulin a chance to start working before sugars start to rise after food digestion. But using this lag time and trying to plan your insulin dosing this way is really hard for a lot of people, especially for our patient. We know that she's never really sitting down to eat a meal. In recent years, we've had ultra rapid acting insulin analog formulations. So these are Lumjev and Fiasp. Fiasp is Novolog with the addition of niacinamide to enhance absorption. And similarly, Lumjev is Humalog that has treprostinil added in, which is a vasodilator that enhances absorption. And these insulins are designed to be taken right at the start of the meal. They're also FDA approved or labeled to be taken up to 20 minutes after the start of a meal. And you can kind of see the kinetics of these different insulins here, but they have a faster onset, faster time to peak effect, and kind of a similar duration of action. But really, the ability to take your insulin as you're eating versus trying to plan it before the meal is a big game changer for a lot of people and can really help manage postprandial hyperglycemia. So this may be a really great option for our patient here.
Thank you, Raisa. So yes, so these are other tools that we have. And okay, so then let's talk about like assessing insulin use. Really, and so then this patient is on a pump. How can I make adjustments? Right, like thinking that maybe the patient is not carb counting. Is it, can we make adjustments there? So then to help her here, because that is the main problem. So then, and this is true, like for any patient who we are thinking on insulin, regardless of whether on a pump or not. So then what we want to do first is to calculate the daily dose, basal and bolus, and then we'll include the correction. I also want to point out that the next echo is going to be about insulin use. So then this is kind of like a brief introduction, and then this will be discussed further detail at next echo. So then the first step is what's the total daily dose, right? Like, so then she is 252 pounds. So that's 114 kilos. And she, based on her pump, the amount of insulin that she was using 76 units a day. So that is 0.6 units per kilogram. So then we want to assess that, right? That's what she's using right now. So then that, when patients are using more than 0.5 units per kilogram, I consider that insulin resistant. She does have normal renal function. She's 55 years old. So then we want to consider all of that. But then if you were to start someone on insulin, but this is kind of how you would calculate the total amount. That's what she's using. Then the step 2 is like, well, of her total daily dose, then we want to divide half in basal and half in prandial insulin. So then she is on 76 units a day. So that is 38 units of basal, 50%. And then the other half, the 38 units, then we would divide that in 3 doses, really. So that would be the prandial insulin, 1 for each meal. So then that's 12.6. I would round to 12. We always kind of err on the side of caution. So that's usually how, you calculate basal bolus. There are also, new thought process that perhaps it's a better idea to just do 30 to 40% basal and then more of the insulin with food, right? Because if they don't want to, if they skip a meal, or then you don't risk for them to go low. But we're kind of like doing this one for now. And then how do we calculate a correction factor, right? So that means that if their blood sugar is a little bit high, right? So then how much insulin they are going to add to correct the glucose. So, and then that's what we call the correction factor, and how to calculate that based on, this calculation of total daily dose and so on. So then we have this formula. So we use 1800 or 1700 with rapid acting insulins and 1500 with regular insulin. She is on a rapid acting insulin. So then when we do the math, then that comes up less than 1800 divided by 76, which is the total daily dose. That's 23.6. So then I would round up to 25. So then again, I always kind of like try to just make it a little easier math-wise for the patient. So then that's how you do it. Sorry. So then these are things that you can then put in the pump, right? So then to motivate the patient to bolus more and to take advantage of the pump. But you can also have these, of course, you have patients on basal bolus and injections and so on. And these are the different closed loop systems that we have currently. And I want to have Nicole to tell us more details about these devices.
Because we're running over time, I just sort of wanted to summarize, like Carol's key question was, these massive glycemic excursions, right? And so, the first thing we discussed was her life stressors, right? And we may not be able to change that. I do think she has her therapist support, and this is someone I would say, because of the situation you're in, we don't have to think about medications indefinitely, but during the 6-month or 9-month period to consider an adjunct. And I wonder if that might help her stress and balance out her glucose a little bit. And then we talked about the more rapid acting insulins, because hopefully they'll keep her from peaking less if you can get one that has a faster onset. And then finally, we also talked about bariatric surgery. Now, it's not the right time for her, but because of her supreme insulin resistance, reducing her weight will probably help her very much with her glycemic excursions. And then the final thing I wanted to point out was there are different types of smart pumps or automated pumps. All of them adjust the background insulin in order to prevent hypoglycemia and go up a little bit in the setting of hyperglycemia. But in her case, because of her extreme excursions, she may need an insulin pump that actually gives a correctional dose of insulin. And whereas the Omnipod goes up and down on their background insulin every 5 minutes based on the predicted blood sugar, both the Tandem and the Medtronic 780 gives correctional doses of insulin. So potentially, if you're still struggling with her insulin management, a different use of an automated pump may best support the person, especially when we're talking about glycemic excursions. And then the final thing would be is given those excursions at night, definitely could be related to her nightmares and stress. I would think a little bit about Cushing's in this patient and just make sure she doesn't have any stigmata of Cushing's and consider an evaluation to rule out that as well. So that would be sort of my summary of the glycemic excursions, and then, brief look at our different pumps and how the pumps may best support her.
Yes. Okay. And so then, the other thing is that, well, if we think that this might be too, overwhelming for her, assessing whether she's still happy with the pump, should we consider other strategies, so then basal bolus or mixed insulin? So, I think the pump is great, right? Like, and then just kind of like maybe learning a little bit more about how to use it, or like bolusing and strategies like that. So in summary, yeah, the A1C goal might not be 7, really, but 7 to 8 for this patient, given her life stressors. But that again, like remember that you want to evaluate the A1C goal every 3 to 6 months. Things change, and then perhaps, hopefully, in the future, once her anxiety, PTSD is better controlled, then she can achieve better control. Teaching simple carb counting might help optimize, the use of the pump. As tolerated, maximize GLP-1 receptor agonist, and then, evaluate, reassess insulin pump. And don't forget about bariatric surgery. Right now might not be the best time to bring that up, but that's an option, and consider that given that her BMI is more than 40.
And we are over time, but I want to just say this ends the Cardiometabolic Echo session 5.